Hi, my name is Aarti Kapoor, and I'm a PhD candidate in the Centre for Public Awareness of Science at the Australian National University. So my research is in the field of science communication, and it focuses on the communication of hysterectomy information to Australian women. In particular, I'm looking at the communication challenges faced by Australian women who are deciding whether or not to undergo the hysterectomy procedure. A quick description of what hysterectomy means. It's a common yet complex surgery that involves the removal of the uterus. It's mostly performed to relieve benign and non-cancerous conditions such as uterine fibroids, uterine prolapse, abnormal uterine bleeding, amongst other conditions. The procedure is usually considered elective, which means that decisions need to be made and options need to be discussed. So in this respect, my research specifically focuses on the dynamics of doctor-patient communication during the hysterectomy decision-making process. And from a broader perspective, I'm also exploring whether science communication can play a role in addressing some of the communication challenges in women's healthcare in general, including whether it can address the communication challenges that often arise in this area as a result of the need to navigate through what might be perceived as uncomfortable topics, namely taboos. This area is of particular interest to me, having undergone the hysterectomy procedure myself a few years ago due to severe uterine fibroids and an almost relentless bodily pain for a number of years. So in the process of decision making, I discovered how difficult it was to ask my doctor questions relating to the procedure. And to be more precise, it was not only about what to ask, but how to ask the questions. The burden seemed to be on me as a patient to ask the right questions, which was made even more difficult in light of the surrounding taboo issues related to hysterectomy. I also discovered that while from the perspective of a gynecologist, hysterectomy is a medical procedure, for me as a patient, it was a journey that continued long after the procedure was done and dusted with from a medical practitioner's point of view. And this journey involved my body slowly adjusting to the physical changes after the surgery, including a gradual onset of menopause. So somehow society has decided that menopause is a taboo issue. I became acutely aware that it is not considered polite or proper to talk about surgeries involving female reproductive organs, even with friends and family. So basically, it was a hush-hush procedure. So all this made my post-surgery recovery experience rather convoluted and hard to talk about while trying to cope with the changes that were occurring in my body after my surgery. And being an elective surgery, I actually began second guessing my decision of having undergone hysterectomy. I wondered whether other women who had or were undergoing hysterectomy had a similar experience, especially in the coping process after the surgery. And how much control and autonomy do women actually feel that they have over their bodies during such surgeries involving their reproductive organs? So I began looking at academic literature for answers and quickly found out that there was a common theme going on. Women needing to make a decision about undergoing hysterectomy were saying, we wish we could ask questions, but at the same time, we don't know what to ask or how to ask. Taboos, of course, worsen the situation. How do women and their gynecologists address taboo issues during consultations? What role does a gynecologist play in helping women to make their decision? How do both parties navigate through taboo issues? What are the expectations of each party? And how do the gynecologists communicate the risks of this surgery? So, as a science communicator, and also because medical science is part of the broader body of science, I wondered, can science communication help shed light on some of these communication challenges? Can it provide us some useful tools to guide doctor patient communication? Hence, I embarked on my research in this area. My research is ongoing and I will be commencing the field work shortly. However, based on my review of existing academic literature, what I have discovered is that there is a strong potential for science communication practices to collaborate with the medical field to meet the communication needs of hysterectomy patients. This has been discussed in detail in a recent commentary piece that I co-authored in the Journal of Science Communication with Dr. Merrin McKinnon, Senior Lecturer at the Australian National University. Our paper looks at some of the potential ways that science communication can play a role in women's healthcare. The paper is entitled The Elephant in the Room, Tackling Taboos in Women's Healthcare. So, a taboo is a subject that is intentionally avoided or not dealt with because it is socially unacceptable or associated with strong feelings of shame and modesty in a given culture. In the context of women's health, taboo topics can be summarized as the 3 M's: menstruation, maternity, and menopause. In the context of a medical setting, taboo has also been described as being two-way, as in a two-way taboo, where neither healthcare professionals nor patients initiate conversations about patient sexuality, potentially leading to patients tacitly believing that their problems are rare, irrelevant, and untreatable. So literature shows us that from the patient's point of view, there are 2 needs that have to be met when visiting their doctor: the need to know and understand their medical condition, and the need to feel known and understood by their doctor. However, if taboos are involved, these needs may not be met. Much of taboo in hysterectomy could be due to the overall symbolic value that society has attached on the uterus. This is more so in some cultures than others. So the uterus tends to be symbolic of youth, fertility, femininity, self-identity, vigor, and vitality. So it's easy to see why this procedure sits at the nexus of the 3 M's of the taboo issues in women's health that I just mentioned, namely menstruation, maternity, and menopause. Because firstly, it's a procedure done to relieve medical problems such as related to the uterus, such as uterine fibroids, uterine prolapse, and abnormal uterine bleeding. This kind of could be compartmentalized onto menstruation. And secondly, hysterectomy deals with issues of fertility, or rather infertility. So that could be compartmentalized under maternity. And thirdly, in hysterectomy, if the ovaries are also removed, then there is the onset of the surgical menopause, which then comes into the 3rd category of the 3 M's, which is menopause. So as hysterectomy is deeply linked with issues of sexuality, which is another taboo in society, what it might mean for many women and healthcare providers is that this very common yet complex surgery is very uncomfortable to talk about, let alone to decide on. Also, the procedure is usually elective. So what this means is that decisions have to be made and options need to be discussed. But the presence of taboos could possibly hinder a meaningful and open discussion during decision making. Being elective also means that choices need to be made in relation to the type of hysterectomy. For instance, partial, complete, radical, or one that involves a concurrent removal of the fallopian tubes and ovaries. So there are various types of hysterectomy. Again, taboos might make it difficult to discuss the implications that each of these types of hysterectomy would have on a woman's post-surgery anatomy. So one of the other challenges that hysterectomy decision-making brings about is the communication of uncertainty, risks, and adverse events. So like any surgical procedure, hysterectomy is accompanied by potential medical risks and uncertainty. But when you add taboo to the mix, it further complicates the communication process. After their hysterectomy, women might need to cope with adverse events such as infection on their surgical site, bladder and bowel injuries, depression, fears about sexual intimacy, and the side effects of surgical menopause, some of them falling squarely within the realm of taboos. And research shows us that physicians are often reluctant to communicate uncertainties to their patients when making decisions. So failure to communicate the risks and uncertainties clearly could arguably hinder the patient's ability to make an informed decision. So another communication challenge that arises during hysterectomy decision making is the communication of complex jargon. Complex jargon is a huge problem in hysterectomy. Even the term hysterectomy is hard for a layperson to understand because the procedure itself is so complex and has so many variations. An example is the term hysterectomy with bilateral salpingo-oophorectomy, which is basically hysterectomy and the surgical removal of both ovaries and fallopian tubes. So for example, if patients are told that their ovaries would be removed, that would probably not have much of implication for them unless they are told that it would mean that they would subsequently experience menopause as a result after the surgery and might, for example, need to consider hormone replacement therapy treatment, or HRT for short, after their surgery. So context does matter. A study in the US found that women are underinformed and even perhaps misinformed about female reproductive organs and the consequences of their removal, particularly those who are younger and from minority groups. Another study shows that many patients and the public in general are unaware of the location of the key body organs, even those in which their medical problem is located. So research also shows us that unexplained medical terminology can be a barrier to effective communication in clinical encounters, leading to patient anxiety. So communicating complex jargon is a problem in hysterectomy, as I've mentioned. But while it is important for a patient to understand complex terminologies as far as it pertains to their decision-making ability, science communication also shows us that focusing solely on scientific literacy is not enough. As we argue in our paper, other factors such as patients' values, beliefs, worldview, and lived experience can also influence their decision-making process. So our paper just seeks to explore this very question. But first, it's important for us to note two things here. Firstly, science communication not only provides us with the tools for effective communication on matters involving science, but it also sheds light on the intricate relationship between science and society. In other words, science does not exist in a vacuum. As I mentioned earlier, worldviews, values, beliefs also matter. In fact, this applies to both patients and doctors. However, in the medical world, there seems to be a dichotomy in this regard. Physicians generally tend to place more relevance on biology when managing their patient's illness, while patient beliefs about an illness are influenced by social and behavioral factors. Secondly, it must be acknowledged that the medical world has, over the years, tried to address the doctor-patient communication challenges, but there have been limitations. So, for instance, the traditional paternalistic model of care, which loosely speaking or loosely translated would mean where the doctor makes all the decisions and the patient has no say, is gradually shifting towards a more gold standard approach of shared decision making, which is more patient inclusive and where both parties try to reach a decision together. But in reality, shared decision-making has been slow to progress. Also, while communication training has been incorporated into medical curriculum, poor communication still continues to be a problem. So one of the things that our paper suggests is that science communication could play a collaborative role with medicine to address these limitations. Basically, we suggest a few ways that science communication can play a role in addressing the current doctor-patient challenges in hysterectomy decision-making. Firstly, with regard to the communicating uncertainty, risks, and adverse events, research has shown that when communicating uncertain outcomes, publics prefer uncertainty to be communicated to them, even in health-related circumstances. In other words, it is useful to communicate uncertainties rather than remain silent about them. So the question that arises is, would this then undermine the trust of the audience, and in this case, the patients? Well, research has shown that notwithstanding the audience's prior beliefs about topics, open communication of uncertainty does not undermine the audience's trust in facts and does not undermine the audience's trust in their communicators. So in the context of hysterectomy, this seems to suggest that openly communicating risk and uncertainty could potentially benefit both doctors and patients in the hysterectomy decision-making process, and that discussing uncertain outcomes does not undermine trust. A second way that science communication can help to address the communication challenges in hysterectomy decision-making is in relation to the communication of complex jargon. In hysterectomy, as I've mentioned earlier, complex jargon can often be very confusing. In general, science communication skills can be used to make communication of complex medical information not only accessible, but also relevant. So this could be done through, for instance, integrating some of science communication's best practices into the medical communication training curriculum. For instance, there have been science communication programs employing theater-based improvisation techniques, or improv techniques for short, used to teach communication skills to medical students, which have improved the subsequent communication in the clinical environment. And the third way that science communication could play a role is with regard to providing some insights into the facilitating of the two-way exchange of information. So science communication has shown that dialogue is basically twofold. It's a dialogue about facts, which has a functional goal, and a dialogue about concepts and notions, including feelings, emotions, and fears, which has a conceptual goal. So dialogue consists of basically a functional goal and a conceptual goal. So what this suggests is that while feelings, emotions, and fears are the non-technical aspects of a dialogue, they're still needed in the process of decision-making. And perhaps consciously incorporating them into a doctor-patient dialogue could potentially enhance the communication process. Navigating through taboo topics is never easy because it is deeply embedded in societal issues. But this should not hinder the medical care that a patient needs to receive. As I've mentioned, in the case of hysterectomy and possibly other areas of women's healthcare, literature shows that there is a strong potential for science communication practices to play a collaborative role with the medical field to address and navigate through inherent taboo issues, even when dealing with risks, adverse events, and complex jargon.